All right, I think we're getting up to our usual number of live viewers. So welcome everybody to today's GDT. It's actually a little bit of a special GDT because we're actually partnering with a patient advocate from an international foundation to hear his perspective and some resources for patients as part of GDT. And this is something that we're going to work towards to try to incorporate into our future GDTs from this point on. So thank you for joining us today. And it is my pleasure to introduce Dr. Zachary Schwager as our speaker today. He will be speaking about pemphigus. So Dr. Schwager is a dermatologist who's practicing at Leahy Hospital and Medical Center right outside of Boston, Massachusetts, where he directs a blistering disease clinic and runs the inpatient dermatology service. Prior to coming to Leahy, Zachary completed medical school at Brown University, followed by dermatology residency at New York University. At Leahy, Zach is also heavily involved with resident education, precepting an urgent dermatology clinic and a continuity clinic for the Harvard Combined Dermatology Residency Program. His clinical research focuses on bullous pemphigoid as well as practice patterns around the use of B-cell depleting therapies in pemphigus. And I'm going to go ahead and introduce our patient speaker as well, just in the interest of time so that we can kind of move seamlessly from Dr. Schwager's talk into Mark Yale's talk. So Mark Yale was diagnosed in 2007 with cicatricial pemphigoid, a rare autoimmune blistering disease. Like others with a rare disease, he experienced delays in diagnosis and difficulty finding a knowledgeable physician. Eventually, Mark lost the vision in his left eye from the disease. This inspired him to help others with this condition. In 2008, he joined the International Pemphigus and Pemphigoid Foundation, or IPPF, as the peer health coach. He worked with people to improve their quality of life and encouraged them to become self-advocates. In 2009, he helped develop the Pemphigus and Pemphigoid Comprehensive Disease Profile, giving experts insight into the patient perspective. In 2016, Mark became the executive director of the IPPF, and in 2020, after experiencing a disease relapse, he moved into the role of advocacy and research coordinator for the IPPF so that he could focus on research and advocacy for all of those affected by pemphigus and pemphigoid. He served as a member of the American Academy of Dermatology Drug Transparency Task Force, the committee advisor for the Rare Disease Legislative Advocates, and as a panel expert for the Rare Disease International World Health Organization Collaborative for the Global Network for Rare Diseases to ensure a lasting impact on the lives of people living with rare disease around the globe. In 2022, Mark helped establish the Global Dermatology Coalition, a multi-stakeholder group of like-minded organizations focused on putting medical dermatology on the global health agenda. He currently sits on the executive board of directors for the International Alliance for Dermatological Patient Organizations as their president, on the board of directors of the Haystack Project, and on the Rare Disease Advocacy Council of the Patient-Centered Outcomes Research Institute, or PCORI. He now resides in Ventura, California with his wife of over 34 years. So we're very excited today to have both a physician scientist and a patient advocate speaking. And it's my pleasure to introduce Dr. Zach Schwager, who will speak about a case-based update on the pathogenesis and management of pemphigus. Zach?
Hi, everyone. Thanks so much for that great introduction. And thank you all for being here today. Thanks to Dr. Richmond and Dr. Damsky for the invitation. As you heard, I'm Zach. I'm a dermatologist at the Leahy Clinic outside Boston, where I run our immune blistering disease clinic. And today I'm really excited to be giving this case-based update on the pathogenesis and management of pemphigus. And we're also joined by Mark Yale, who you heard about, and he'll be joining us to speak about all the incredible work that the IPPF does as well. So here are my disclosures. I do serve on a scientific advisory board for Boehringer Ingelheim, but it's not related to immune bullous disease or anything we'll be discussing today. And I will be discussing off-label use of medications. So here's our roadmap. I'll give a brief kind of historical perspective, and then we'll meet our patient, who's going to be our guide as we talk through the most up-to-date science around the pathophysiologic understanding, diagnosis, and treatment of pemphigus. Then we'll speak a little bit about future directions in therapy, and then finally hear from Mark about the IPPF. So I think it can be useful to look back briefly and kind of set the stage prior to jumping to the most current science, just to kind of contextualize where we are now and how far we've come recently in understanding pemphigus and these types of diseases. If we get in our DeLorean and go back in time, we can actually see, historical texts that describe symptoms which could be consistent with pemphigus up to, the 5th century BCE at least. These were sort of chronic mucocutaneous blistering diseases, maybe something like pemphigus or pemphigoid. In the 1700s, we first see the term pemphigus come out in medical texts. Like a lot of terms at that time, it was fairly nonspecific and used to describe all kinds of blistering disorders. And the earliest use of the term is probably describing something that we would recognize today as erythema multiforme. Later on in the 1800s, the term becomes more restrictive and is used to describe more chronic mucocutaneous blistering disease. So probably pemphigus and pemphigoid. And then in the 1950s, the breakthrough comes of distinguishing these diseases based on histologic grounds. So the discovery that pemphigus represents an intraepidermal blistering disease, right? And pemphigoid is a subepidermal blistering disease. So finally, these patients are split apart based on clinical and histologic grounds. Following that, direct immunofluorescence is developed and autoantibodies are visualized on keratinocyte cell surfaces in pemphigus patient skin samples. And this was the first clue that autoantibodies and autoimmunity were at work in these diseases. Subsequently, those antibodies were purified and the antigen was determined to be desmoglein 3. So here's a nice summary of some of the key developments over the last 60 years or so, which have really informed our modern understanding of the pemphigus disease family as this intraepidermal blistering disease caused by autoantibodies against components of keratinocyte cell adhesion molecules, or desmosomes, specifically desmogleins, which make up the little intracellular, parts of that desmoglein adhesion molecule there. So, remember that this disease was first described as far back as 2,500 years ago, and this is just the last 60 years, so pretty remarkable progress recently, but still a lot we don't know about these diseases. Likewise, management has evolved over time. Pemphigus, especially pemphigus vulgaris, was typically fatal prior to the advent of glucocorticoids in the 1940s. Especially patients with severe disease would become unable to eat, had loss of skin barrier function, and could become infected. Systemic steroids were definitely a game changer because they represented a rapid acting and effective treatment. But these patients now had a different problem, which was the high morbidity and mortality associated with long-term high-dose prednisone use. So subsequently, steroid-sparing agents were developed to try and limit prednisone exposure. And these can work okay, some of them better than others. More recently, rituximab has come to the forefront as our first-line treatment, and there's even newer treatments in development as well that I'll be speaking about. Okay, so let's get back in our DeLorean and come back to the present to kind of meet our patient who's going to be our guide as we move through this talk. So imagine that we're in clinic and we're about to meet a patient who's been referred to us for blistering lesions in the mouth and on the skin. We walk into the room here, we meet Mr. Q. He's a 55-year-old gentleman. Previous to this was relatively healthy, but he's now had 3 months of these progressive, painful oral lesions. And more recently, over the last couple of weeks, began to develop some lesions on his back too. Over that 3-month period, he's bounced around and seen a couple of different healthcare providers. He's been to some walk-in clinics and ER, seen his PCP as well. He was given a couple of treatments, including nystatin, swish, and spit, some fluconazole pills, courses of valcyclovir. But unfortunately, his symptoms have continued to progress, and he's now finding it difficult to eat and drink because of the pain. And because of that, he's lost some weight, he's becoming weak, and not really able to work anymore. So he's on disability because of this as well. And he's feeling quite depressed and quite hopeless. He's fearful his symptoms are to continue to progress, and also frustrated that no diagnosis has been made despite seeing a bunch of different healthcare providers. So he's in a pretty dark place, both physically and emotionally, when we meet him here. Current meds are only Lipitor. As a bit of background, he was born in Taiwan, but moved to the US as a teenager. So unfortunately, this is kind of a common presentation, right? Pemphigus is relatively rare and not well recognized outside dermatology and a few other specialties. So these patients often suffer for many months before they're able to see a specialist and get a diagnosis. It's common to see pemphigus patients bounce between urgent cares, ERs, dentist office. They can be misdiagnosed as having HSV, thrush, or other infectious diseases. And as with our patient, there's a really high level of depression, fear, and anxiety in this population, and really just a devastating effect on quality of life. So here's a clinical photo of Mr. Q's mouth. You can see the diffuse, deep erosions over the hard palate here extending to the oropharynx as well as over the buccal mucosa. Some more photos, you can see red erosions over the hard palate, a little bit over the buccal mucosa here too. Over the back, there's moist red erosions and a few small flaccid-looking blisters. I want to provide some more examples of how patients like Mr. Q might look, but I wanted to provide images that show the disease in different skin types and also at different severity levels too, just to give you guys an idea of the spectrum of disease here that you might see in your patients. So here's some more sharply demarcated oral erosions, and then on the back, these typical cutaneous lesions which show moist erosions and ruptured flaccid blisters there. Here's another diffusely eroded palate. More extensive cutaneous lesions with these really characteristic red, moist, erosive lesions with, denudation of the overlying epidermis there. These patients can also have significant upper airodigestive lesions too. You can see here, this is a picture of the epiglottis, and these ulcerations or deep erosions at the tip of the epiglottis are highly characteristic of immunobullous disease, like pemphigus. You can also get esophageal lesions that can lead to odynophagia, dysphagia, even strictures if scarring occurs. Patients can also get genital mucosal lesions, ocular lesions as well. They're more rare in pemphigus than some other immunobullous diseases. Here's a patient with more extensive erosive cutaneous disease with high BSA epidermal loss. In severe cases like this, you can get almost a TEM-like clinical picture with really catastrophic loss of barrier function in the skin. This is a photo showing lots of flaccid appearing, easily ruptured blisters. Sometimes they can take on almost a turbid or pustular appearance too, but you can see these characteristic, red moist erosions here where the lesions have ruptured. So obviously this is a talk about pemphigus, so that seems like a pretty good bet for the diagnosis for Mr. Q, but I think that talking through a differential will really help to explain the tools we use to diagnose pemphigus and other autoimmune blistering disease. So again, pemphigus vulgaris seems likely. We could think about pemphigus foliaceus, though we expect these patients not to have mucosal disease, right? And we expect their cutaneous lesions to be more superficially encrusted. We could consider paraneoplastic pemphigus. These patients usually have a really severe intractable hemorrhagic mucositis with crusted, erosive, and ulcerated lesions over the vermilion lip. Majority of them also have no malignancy, though not all. Or could this be pemphigoid? Up to 20% of patients with pemphigoid can have mucosal lesions. I think this goes under-recognized. Usually they're not as extensive as we've seen in this case, but they do exist. However, typically these patients are much older. Our patient is in his 50s. Typically, pemphigoid patients will be older in their 60s, 70s, and 80s. The clinical presentation is also different, right? These patients have tense blisters, which are more difficult to rupture and usually leave larger crusted erosions than we're seeing in our pemphigus patient. We could also consider non-immunobullous diseases as well, like those listed here. So we think this is a reasonable differential, and we think that Mr. Q's presentation is concerning for pemphigus. What would be our next steps, right? So typically the workup consists of a lesional skin biopsy, usually at the edge of a blister, and then a perilesional skin biopsy, right, about 3 millimeters away of normal appearing skin to try to use direct immunofluorescence to visualize bound autoantibodies in tissue. It's also become standard to get serum for indirect immunofluorescence as well as enzyme-linked immunosorbent assay, or ELISA. And ELISA is a pretty neat tool. We use it to detect the presence and levels of pathogenic antidesmoglade antibodies. It's actually more sensitive and specific than IIF. It can be a neat tool as well to follow patient progress after treatment and perhaps predict recurrences and guide retreatment. So here's the pathology from our patient. You can see there with the H&E, there's intraepidermal vesiculation with rounding up and acantholysis of keratinocytes. There's this characteristic tombstoning of basal keratinocytes just above the dermal epidermal junction, and a nice split in the lower epidermis. All of this highly consistent with what we would expect in pemphigus vulgaris. Likewise, the DIF is characteristic of pemphigus vulgaris with this chicken wire-like pattern of immunofluorescence in the epidermis, and this represents keratinocytes, autoantibodies bound to keratinocyte cell surface. So again, consistent with pemphigus. What ELISA findings will we expect? Remember that we're sending off blood to detect ELISA levels of desmogleins 1 and 3. Based on the patient's clinical presentation, can we predict what his ELISA profile will be? Well, we can. We think that because he has cutaneous and also mucosal lesions, he's going to have desmoglein 1 and 3 positivity. And we can surmise this because of something called the desmoglein compensation theory. And this is basically a model that helps us to correlate disease phenotype with autoantibody profile and vice versa. And there's a little cartoon here from Bologna that shows how it works. Briefly, I'm sure most people are familiar. But mucosal skin contains only desmoglein 3. Skin contains desmoglein 1 and desmoglein 3, with desmoglein 1 predominating more superficially. So for a pemphigus vulgaris patient that has only anti-desmoglein 3 antibodies, they will have mucosal lesions because desmoglein 3 is knocked out in mucosa, but no skin lesions, right? Because desmoglein 1 is there to compensate for the desmoglein 3 that's lost. Many patients with pemphigus have epitope spreading and go on to develop anti-desmoglein 1 antibodies, as in our patient. These patients then develop cutaneous disease as well as mucosal disease because now desmoglein 1 is knocked out in the skin in addition to 3, and they can no longer compensate for each other. Patients with only desmoglein 1 autoantibodies have a different disease. We call this pemphigus foliaceus. And these patients have just superficial blisters of the skin, no mucous membrane blisters, because these mucous membranes don't contain any desmoglein 1. So it's a nice model and it can be really useful. However, like most things in life, it's probably not that simple. And there's a lot of recent data that raises questions about whether or not this concept sufficiently explains pemphigus vulgaris or foliaceus. And it's likely that the pathogenesis is more complex than this. And we can think about this because of a couple of different reasons. The most important of which is that it's not a perfect model, and there's a fairly high level of discordance between clinical and serologic profiles. Up to a third of cases may not match up, with the serology not accurately predicting the clinical phenotype and vice versa. We also know that we can see elevated titers of desmoglein antibodies in asymptomatic patients and also patients with treated disease in remission. So there's been a lot of other autoantibodies described in patients with pemphigus. These include other kind of cadherin type molecules like desmocollin 3, desmoglein 4, other things like acetylcholine receptors and something called pempaxin. There's also been a recent discovery of auto antibodies that seem to be directed against mitochondrial antigens, though the significance of that is still being worked out, though all of these are thought to potentially play a role. The other thing is that it's likely that not all desmoglein antibodies are created equal, and pathogenicity may actually differ depending on what epitope an autoantibody is binding to on desmoglein. So back to Mr. Q. Based on the clinical, pathological, and serologic data that we've reviewed here, we diagnosed Mr. Q with pemphigus vulgaris. He's there with some family, and understandably, they have a lot of questions about this diagnosis. So the first is, what is pemphigus and what causes it? We've talked a bit about this so far. We know that pemphigus is an autoimmune blistering disease that affects the skin and the mucous membranes. We know that it's mediated by circulating autoantibodies to desmogleins, which are a key component of intercellular keratinocyte adhesion molecules in the epidermis called desmosomes that hold keratinocytes together in the normal epidermis. And we know that these autoantibodies are produced by a clonal population of autoreactive B cells. So all of this was parsed out by some pretty interesting and elegant experiments. In vitro, if you take cultured keratinocytes or even human skin explants and expose them to pemphigus vulgaris patient serum or purified IgG autoantibodies against desmogleins, you can induce acantholysis or blistering. In vivo, there's been a series of passive transfer experiments that really identified autoantibodies as the key pathologic factor in these diseases. Basically, transfusing a mouse with pemphigus vulgaris patient serum can induce blisters that clinically, histologically, and immunofluorescently are identical with pemphigus. And if you take that serum and use immunosorption to remove desmoglein antibodies, that serum is then unable to induce blistering in the mouth. So all this really implicates anti-desmoglein antibodies as central to the pathogenesis of this disease. Here's a little schematic of the in vitro study showing that adding pemphigus serum or purified IgG to skin explants or cultured keratinocytes causes blistering, depletes desmosomes, causes acantholysis. And likewise, here's a nice summary of the important mouse transferred immunization models that cemented the pathogenic role of anti-desmoglein antibodies in autoreactive lymphocytes in causing pemphigus. So these include, like I said, the passive transfer models of pemphigus vulgaris serum, purified anti-desmoglein antibodies, and even antibody fragments. Then the active transfer model, where you actually immunize desmoglein deficient mice against desmoglein 3, then transplant those lymphocytes into another immunodeficient mouse, you get the production of a pemphigus phenotype. So that kind of implicates autoreactive lymphocytes as the cells responsible for creating these autoantibodies, and then an active immunization model in a genetically engineered mouse as well. So here's a really important point. Passive transfer of antidesmoglein antibodies causes blistering in mice, even in mice that do not have a cellular immune system. So if you take a cellularly deficient mouse that doesn't have B cells, T cells, or polymorphonuclear cells, and transfuse them with pemphigus serum, they still develop blisters. And this confirms that autoantibody-mediated acantholysis does not require an inflammatory infiltrate. Antibodies themselves are necessary and sufficient to cause blistering. Contrast this with some other autoimmune blistering diseases like bullous pemphigoid, for example. In BP, you really need that inflammatory infiltrate of newts, EOs, lymphocytes to come in and chew up the DEJ to cause blistering. Not so in pemphigus, where just the binding of those antibodies to desmoglein induces blistering. And we'll come back to this. So we know from these experiments that all we need is the antidesmoglein antibodies to cause blistering in pemphigus, but let's look a bit closer at how exactly antibody binding to desmogleins causes that acantholysis and clinical symptoms. So for a long time, it was assumed that autoantibodies cause acantholysis purely via what's called steric hindrance upon binding to desmogleins. So basically physically blocking normal desmoglein interactions in the desmosomes that hold keratinocytes together. If you think back to organic chemistry, steric hindrance is the idea that one molecule can physically block another. And that's kind of what the little cat cartoon up here is supposed to represent. Um, Despite that theory, there's increasing evidence that intracellular signaling probably also plays an important role, specifically by something called the p38 MAP kinase pathway, which probably plays an important role in amplifying that acantholytic signal inside the cell. So here's an interesting figure that looks at signaling dependent versus independent loss of adhesion that occurs with autoantibody binding. Normal desmoglein function is seen at the top here. You can see that autoantibody binding desmogleins causes loss of adhesion via steric hindrance, but there are other things going on too. Binding of the autoantibody causes clustering of desmogleins on the cell surface and eventually endocytosis, which then activates the p38 MAP kinase pathway. So let's speak a bit more about the p38 MAP kinase pathway. David Rubenstein's group at the University of South Carolina has done a lot of this work, and they showed that pemphigus IgG binding to keratinocytes actually initiates an intracellular phosphorylation event and activates the p38 MAP kinase pathway, which downstream leads to cytoskeletal reorganization related to acantholysis, right? So that rounding up and changing of cell shape. Enhanced endocytosis of desmogleins on the cell surface, and overall decreased expression of adhesion molecules. So all of this is contributing to further acantholysis. Here's a more zoomed in look at the pathway, and you can see that there's several different enzymatic cascades that lead to cytoskeletal rearrangement, enhanced endocytosis of desmogleins, and propagation of acantholysis. So could this be a therapeutic target, right? Some experiments with p38 MAP kinase inhibitors in knockdown mice have shown a protective effect against the acantholytic activities of antidesmoglein 3 antibodies. This group used a p38 MAP kinase inhibitor to prevent acantholysis in vivo when mice were exposed to pathogenic antidesmoglein 3 antibodies. You can see here, this is mice exposed to pemphigus vulgaris IgG, and this is exposure in the setting of the MAP kinase inhibitor. And you can see these mice have no blistering. And this is the corresponding histology here. You can see this is with the pemphigus IgG, and this is with the inhibitor. There's no blistering happening. So that seems pretty promising, right? Unfortunately, though, this strategy has not really borne out in every experiment. In a lot of cases, you can still have shearing or Nikolsky type induced acantholysis. That wasn't prevented. And in a lot of experiments, acantholysis still occurred even in the presence of the inhibitor, particularly in cases where systems were exposed to purified monoclonal desmoglein 3 antibodies. In clinical trials for MAP kinase inhibition in pemphigus and other diseases too have generally been disappointing in terms of efficacy, but also in terms of just treatment limiting side effects of these types of therapies. It seems like the p38 MAP kinase pathway may be too globally important to kind of shut down wholesale. So while interesting, this approach hasn't really borne out so far, but there may be aspects of it too that could still be a target in the future. I think the prevailing theory at this point is that there are actually multiple converging pathways to acantholysis. It's likely that the physical binding of those autoantibodies and the steric hindrance is still the crucial event that causes acantholysis, but that intracellular signaling plays an important role downstream and kind of propagates and amplifies that discohesion of the epidermis and could be potentially a target for some therapeutic interventions. Okay, so far we've spoken a lot about pathogenic autoantibodies, and we know these are produced by autoreactive clonal population of desmoglein 3 specific B cells. But what about T cells, right? So I'm not an immunologist like Dr. Richmond, but I seem to remember that behind every clonally expanded B cell population, there's often a CD4 T cell at work. So could that be the case in pemphigus? Indeed, there is early evidence for pathogenic desmoglein 3 specific T cell at work in pemphigus. And this makes a lot of sense since, as I'll discuss, there are known HLA2 polymorphisms associated with pemphigus, which would seem to implicate T cells. We can also see that there are desmoglein-specific T cells of the Th1 type that can be isolated in healthy individuals carrying these pemphigus vulgaris predisposing HLA types. So they may already have these T cells. However, where it gets interesting is that patients with pemphigus have Th2 type desmoglein 3 reactive T cells. So this tells us that perhaps pemphigus is a Th2 type mediated disease with a type 2 inflammatory milieu. There have been some studies with transgenic mice in which human desmoglein 3 T cells can induce the production of anti-desmoglein 3 antibodies, but this hasn't been seen in humans to this point. Though it's still the theory that this is what's going on, and this is the theory here. In a healthy state, you have central tolerance within the thymus, and then peripheral tolerance against autoreactive T cells by the activity of T regulatory cells. The thought is that in pemphigus, there is likely a desmoglein-specific Th2 helper cell, which activates desmoglein 3 specific B cell, causes clonal expansion, affinity maturation, and class switching to IgG. So these T cells also seem to be imposing sort of a Th2 or type 2 immune milieu, as well as a type 3 immune milieu, and also downregulate T regulatory cells, all this contributing to disease activity in pemphigus. So we say that T cells could be playing a role, and it's hypothesized that these T cell secreted cytokines could also drive pathogenesis. Pemphigus seems to be, as I said, a Th2 mediated disease with overexpression of type 2 cytokines, so IL-4, IL-6, IL-10. Recently, it's also been discovered that Th17 subset of T cells could be important, and there's overexpression of IL-17 within blister fluid. So perhaps there's a type 3 kind of immune hyperactivation going on here as well. As I'll touch on, T cell activity and T cell derived cytokines could be targets for therapy in pemphigus, and that's another angle that this information is kind of being exploited. So now the patient asks, I understand all that. I understand what the disease is, but why did I get this disease? Why me? And this is actually, I think, a pretty good question because it is quite a rare disease. 1.8 cases per million per year incidence, about 98 cases per million prevalence worldwide, and about 30,000 cases in the USA. And just for reference, the NIH considers anything less than 200,000 Americans being affected to be a rare disease. So pemphigus definitely qualifies. Like a lot of these rare diseases, we don't understand why people get this, but the thought is that there's some genetic predisposition and then some kind of environmental stimulus that may set the disease off. As I kind of referenced before, pemphigus is associated with certain HLA class 2 polymorphisms. Those exact susceptibility genes vary depending upon geography and ethnic origin too. Interesting that we can see low titers of desmoglein 3 specific autoantibodies in asymptomatic relatives of pemphigus patients. And we know that first-degree relatives of pemphigus patients are more likely to have autoimmune disease too. So clearly there's an important element of genetic susceptibility in these patients, and many of them may have pre-existing or pre-circulating anti-desmoglein antibodies long before the development of the disease. Lots of environmental stimuli have been proposed. The most recognized is, of course, endemic pemphigus foliaceus or Fogo salvejum in Brazil. And this is where genetically predisposed individuals living in rural locations, usually near rivers, in areas where this Similium black fly is prevalent, develop pemphigus foliaceus, usually at a young age. And a lot of times when these people move away to urban areas, it goes away, but it recurs if they move back to rural areas where the black flies are prevalent. And the thought here is that this is a population of genetically susceptible people. They have a certain HLA polymorphism that puts them at risk for this. And they're repeatedly bitten by insects like the black fly, eventually causing them to produce antibodies to salivary antigens of these insects. Then through something like molecular mimicry, these antibodies cross-react and attack desmoglein 1, causing pemphigus foliaceus. So pretty interesting. Ultraviolet radiation is also a well-known exacerbating factor in pemphigus. Especially pemphigus foliaceus patients can be extremely photosensitive. This is something important to counsel our patients about. Pemphigus has been seen to arise following things like thermal burns or electrical injuries. So definitely some element of epidermal injury could be at play in some of these cases. Viral infections, certain food, ionizing radiation, pesticides have all been proposed as well, though I think data is really lacking there. We also know that drugs can precipitate pemphigus. Usually with drugs, the clinical phenotype is that of pemphigus foliaceus. The interesting thing here is that a lot of these times it's probably not an immunologic mechanism, but rather a direct acantholytic effect of usually the thiol groups on these drugs against desmogleins and keratinocytes. So for that reason, a lot of times these patients will actually be DIF negative. They won't have bound antibody. This is a nice figure. This shows how environmental stimuli can kick off stress signaling, antigen exposure, and autoreactivity in genetically susceptible individuals. So things like UV rays, insects, infections, other irritants in the skin. Here's one of my pemphigus foliaceus patients who was very well controlled, but got cosmetic laser against my advice. She ended up getting pulse dye laser on her face, and you can see that there's little flares at pemphigus foliaceus that correspond to the laser treatment zone. So this is just a real life example of environmental stimulus driving disease. So let's go back to Mr. Q, our patient. He says, now that we've gone through all that, doctor, is there a cure? What hope do I have to get better? So at present, we can't guarantee a cure to these patients, but the good news is that this is no longer a fatal disease, and we can reassure patients that we have effective therapy that can limit long-term steroid exposure. We have kind of a two-pronged goal when addressing these patients with newly diagnosed pemphigus. One is rapid disease control. We want to stop blistering. We want to heal existing blisters. And then in the long term, we want to suppress pathogenic antibody production and then maintain that remission with minimal systemic glucocorticoids. Many patients can have long-term remission off therapy, and I'll get a bit more into that. There's kind of new hope that this could be a realistic goal for more of our patients. But most patients, we can reassure them that they have reasonable hope of having long-term remission on at least minimal therapy. So the outlook is good. So what are our treatments? Historically, glucocorticoid monotherapy was kind of the only game in town, but unfortunately, while it was effective in controlling the disease, it's associated with really unacceptably high levels of treatment-associated morbidity and mortality that we all know come along with long-term high-dose steroid use. So subsequently, different steroid-sparing agents were developed. Things like methotrexate, mycophenolate, azathioprine were used, usually to supplement and eventually replace the steroids for a patient. These have had variable outcomes in terms of their ability to control disease and also haven't consistently demonstrated steroid-sparing effects. So many of the patients on these treatments still have inadequately controlled disease and are probably still getting too many steroids as well. Most recently, the anti-CD20 monoclonal antibody rituximab has emerged as really the preferred first-line treatment for the vast majority of patients with pemphigus. And this is because it has demonstrated efficacy. It does a really good job of inducing disease remission, but it also has a well-documented and well-demonstrated steroid-sparing effect. So these patients really do get less steroid, which is very important. In general, with these patients, our initial management still does include steroids. So we usually give steroids up front to obtain rapid disease control, while longer-acting therapies like the rituximab take effect. Then, as soon as possible, prednisone can be tapered off altogether, ideally, or maintained at very low levels if needed. Just as an aside, I always thought this was kind of an interesting question that comes up, right? How is it that prednisone works to improve pemphigus so rapidly? I had said that autoantibodies are necessary and sufficient to cause acantholysis. We know that giving someone prednisone for a few days doesn't immediately decrease their levels of pathogenic autoantibodies, yet patients can respond really rapidly to prednisone. Often they get better within a few days or a week. How could this be if we're not decreasing autoantibody levels? Well, it turns out that corticosteroids actually have a direct anti-encapsulytic effect on keratinocytes. It actually causes keratinocytes to beef up their resistance to the circulating autoantibodies. They have increased expression of adhesion molecules like desmogleins and desmosomes and other cadherins. The size of the desmosomes actually gets bigger as well. So patients can have clinical improvement within days, despite no decrease in the level of autoantibodies. Eventually those steroids will cause B and T cell levels to go down, but that takes several weeks. So the steroids actually increase keratinocyte resistance against autoantibodies, which is pretty interesting. So back to rituximab. As I said, rituximab has really become the preferred first-line treatment for the majority of patients with pemphigus vulgaris and foliaceus. And this was really established by the RETUX-3 trial, published in 2017 by Dr. Joly in France. And I'll break that trial down in a moment. There's also increasing evidence that deploying rituximab early on in the disease course is very important, and this is beneficial and increases the likelihood of sustained remission off therapy. This brings up an idea called disease hardening, which is that if you have patients with longstanding untreated or inadequately treated disease, there's probably a phenomenon of epitope spreading, affinity maturation of antibodies, and the development of long-lived memory B cells that may make their disease harder to treat and could make it much more difficult for this type of patient to achieve a long-term remission. All of this kind of culminated rather in the FDA approval of rituximab in 2018. And since then, it's really cemented itself as first-line agent for these patients. So here's the RETUX-3 trial. It compared rituximab to steroid monotherapy and followed patients for 3 years. The primary endpoints were measured at 2 years. And it showed that at 2 years, basically 90% of patients getting rituximab were in complete remission, while only 34% of prednisone alone patients were. And there were many more adverse events in the prednisone group. So this showed that rituximab is superior to steroid monotherapy. This is another important trial that compared rituximab to mycophenolate. I think this is in a lot of ways even more important because if you think about it, clinically, patients were not getting steroid monotherapy. They were usually treated with a steroid-sparing agent. So I think it's much more clinically relevant to compare rituximab to sort of the standard of care, which was a steroid-sparing agent like mycophenolate. And again, rituximab was found to be superior to mycophenolate, more remissions, fewer flares, less prednisone, and a greater reduction in anti-desmoglein 3 antibody levels with treatment. Rituximab is probably also less expensive long-term. I mean, certainly there are higher upfront costs associated with rituximab relative to things like corticosteroids or steroid-sparing agents. But if you factor in the need for ongoing treatment of relapses, management of treatment emergent adverse effects on prednisone and things like that, there is some evidence to suggest that rituximab actually ends up coming out ahead over time. And I think this is an interesting and important study from France that showed that. So just to talk a bit more about rituximab, it's a chimeric monoclonal antibody to CD20. We know CD20 is expressed on the surface of most B cells, and rituximab depletes CD20 positive B cells by a couple of different mechanisms. They're listed here. And it does so quite effectively. Usually peripheral B cell levels drop to near zero in about 2 weeks. The important thing to remember is that plasma cells in tissue are CD20 negative, and these are the cells that are pumping out the pathogenic autoantibodies. So tissue plasma cells remain active, and so anti-desmoglein antibodies don't drop right away. That takes about 4 to 12 weeks, which is basically the time it takes for those tissue plasma cells and plasmablasts to kind of die off. They're not being replenished by B cells in the periphery because we've knocked all those out. So once those plasma cells die off, then the anti-desmoglein antibody levels drop and we can expect to see clinical improvement. But again, this could take 4 to 12 weeks. So just remember, rituximab doesn't work super quickly. And that's why we rely on prednisone and other immunosuppressants to achieve more rapid disease control while rituximab takes effect. So a patient may ask, that sounds good, but how do I know if rituximab will work for me? Are there any predictors of a good response? And again, first-line use of rituximab within 6 months is associated with complete remission off therapy, but there are some other things as well that we can talk about. There's 2 dosing protocols presently that are used for patients with pemphigus getting rituximab. One is the RA protocol. This is 1 gram IV given 2 weeks apart. The other is a lymphoma protocol, which is based on body surface area. So 375 milligrams per meter squared body surface area given weekly over 4 weeks. There's some early evidence to suggest that perhaps the lymphoma protocol may provide a higher chance of complete remission. Conversely, having a BMI above 35 and having a very high baseline anti-desmoglein antibody level by ELISA seem to be negative prognostic factors for achieving complete remission. Now the patient says, okay, based on everything you said, I agree that rituximab makes sense for me, and I think that it's a good idea that I get treated with rituximab. But if I do take it and get better, what can I expect? Will my disease come back? So according to most existing studies, the majority of patients do seem to relapse after rituximab therapy. It doesn't seem to be curative for them. There's this repopulation of autoreactive B cells, an increase in anti-desmoglein antibodies, and clinical relapse. Usually we don't see relapse prior to 6 to 8 months, since that's how long it takes for B cells to repopulate. The median time is around 25 months in the largest studies. However, the really important thing to remember here is that rituximab has only been FDA approved as first-line therapy since 2018, right? So a lot of the patients in these studies had long-standing or refractory disease prior to treatment with rituximab. A lot of them probably had this disease hardening and didn't get rituximab first line. So could they be kind of, confusing the data a little bit here? And does this apply to patients like the one we're counseling here? So why is it that patients relapse anyway? There's a couple of theories that have been put forward, right? You get B cell repopulation in 6 to 12 months. That can be followed by re-increase in anti-desmoglein 3 antibodies and then clinical relapse. If you think about it, there's a couple of explanations, right? One is this idea of acute loss of tolerance. This is that there's this one-time loss of tolerance event, and you have this autoreactive anti-desmoglein B cell. You treat with rituximab, but you don't completely eliminate that clone. You knock it down to a low level, so patients are in clinical remission, but that clone reappears, and it's that same anti-desmoglein 3 antibody producing B cell in the recurrence as was in the initial disease. It's the same population of B cells. The other idea is this idea of chronic loss of tolerance, which is a little more scary. This is the idea that a patient is unable to maintain self-tolerance. So you knock out that additional autoreactive B cell clone, but there's another loss of tolerance event in the appearance of a new population of anti-desmoglein B cell different than in the original disease. Or could it be that there's some kind of long-lived CD20 negative plasma cell hiding out somewhere that's leading to recurrence? So the best available data that we have looking at B cell repertoires in pemphigus patients suggests that it's this acute loss of tolerance, or basically the same B cell clone that was causing the initial disease reappears to cause reoccurrence. It's likely that there could be an element of long-lived plasma cells, especially in patients with hardened disease, but the main thing seems to be that same population of anti-desmoglein 3 B cell reemerging, which if you think about it is a bit of a relief, right? So that's the upper model here. So we treat patients, we knock down but don't eliminate the clones, and they come back and cause relapse. Because if you look at this model, it suggests that if we can just eliminate these clones somehow, then patients could have hope for a complete remission off therapy, and that could be durable. If it was chronic loss of tolerance, then patients would be in a difficult position because even if we completely destroyed all their clones, they could develop new ones. But luckily, it seems to be that it's the acute loss of tolerance that's at play here. Here are some factors associated with relapse after attaining complete remission. This is more work from Dr. Jolie. Basically having a high BSA involvement or a high PDI score at the time of presentation can predict shorter remission. PDI score is a clinical tool used to grade the severity of pemphigus in clinical studies, kind of like a PASI score for pemphigus, if you think about it that way. Another negative prognostic factor would be failure to achieve autoantibody negativity by ELISA during clinical remission. So these patients are at higher risk for relapse, having a positive DIF or IIF during remission. And then patients that are in remission, if they're found to have an increasing level of anti-desmoglein antibodies, specifically desmoglein 3 antibodies above 130 international units per milliliter, that is thought to be a risk for relapse. So I typically check IIF and serologies, ELISA, B cell levels every 3 to 4 months to keep track of patients and see who might be at risk for relapse. I've alluded to this a few times. This is a really exciting and recently published study with longer follow-up from the RETUX 3 trial. So this study followed up and showed that patients treated with rituximab first line, so right, subgroup analysis, right, of all those patients, those that were treated first line with rituximab were much more likely to have a sustained response without the need for further infusions. And it shows that the higher historical relapse rate was probably related to the inclusion of patients with this long-standing partially treated disease. They had that hardened disease with lots of epitope spreading, long-lived tissue plasmablasts, maybe memory B cells. So this says that first-line treatment may offer a very high chance of sustained complete remission without the need for further treatment. Here they showed that 72% of patients who got rituximab first line were disease-free without further treatment at 7 years. And this data also it suggests something else really interesting that isn't immediately apparent, but it kind of, you think about it a little more. It says that patients that got rituximab one time have this complete remission for 7 years, right? So it kind of suggests that that temporary reduction in blood B cells that rituximab exerts is probably not directly responsible for the long-term sustained complete remission that patients have, but rather that there's something going on with regulatory B and T cells where rituximab is kind of retuning the cellular and humoral immune system to block the reappearance of autoreactive lymphocytes. Here's a study that looked at that in a nice schematic. And this figure shows that unlike with steroid treatment, which is up here, treatment with rituximab, it leads to modulation of desmoglein-specific T follicular helper cells and decreases desmoglein B cell specific B cell maturation, class switching, and affinity maturation. So it really suggested, something else going on here with how rituximab is exerting its therapeutic activity in these patients, and really interesting from an immunologic point of view. I'd love to hear Dr. Richmond see what she thinks about this. This is still all being worked out, but this is kind of the theory right now. So again, all of this sort of underscores the importance of rituximab therapy early in the disease, right? Before hardening can occur. This gives patients the best chance of a long-term complete remission that's durable. So what's on the horizon for rituximab? Well, what about maintenance therapy, right? Some studies support the use of prophylactic maintenance infusions of rituximab every 6 to 12 months to prevent relapse. Or should we be using serologic parameters to guide retreatment, things like desmoglein levels, B cell count, CD4 counts? What about dose optimization, RA versus lymphoma dose, which I touched on a little bit? Could there be a role for ultra low dose rituximab, like doses of 500 milligrams, which could be beneficial, but decrease immunosuppression? And then what's the role of IVIG? I didn't really get too much into IVIG, but this is controversial in pemphigus, and its use as an adjuvant or a monotherapy is being looked at. So these are all important questions that are being pursued when it comes to rituximab. The last thing I wanted to end with before moving on from Rtux completely is this study by Jolie et al. That was presented at the AAD this year. And this is really interesting. This is an ongoing study, but I think they recently published part of this data. In this study, they took newly diagnosed pemphigus patients, right? So first line treatment. So newly diagnosed patients were treated with rituximab at an RA dose, so 1 gram, 2 weeks apart, and then monitored from there with desmoglein and ELISA levels. At 6 months, patients who were considered high risk for relapse, so remember the things that I spoke about, having a high baseline P-DI score, or having elevated levels of ELISAs to desmoglein 3 antibodies in remission, those high-risk patients were retreated with rituximab 500 milligrams. Patients who did not have those risk factors were not retreated. And what they found is that almost all of the low-risk patients remained in complete remission without the need for retreatment, as did nearly all of the patients empirically retreated. So this suggests that if rituximab is used first line, only high-risk patients might require maintenance therapy. So perhaps this is sort of more of a personalized approach with rituximab that could be useful. So what about new treatments in the pipeline? This figure shows existing therapies in blue and therapies under development shaded in beige, of which there's quite a few, as you can see. So there are improved anti-CD20 monoclonal antibodies under development, basically a better mousetrap, right? Improved rituximab. Each of these has some potential advantages over rituximab in terms of superior B cell depletion. Veltuzumab in particular is interesting because it can be given by a subcutaneous infusion, and a lot of these are currently under trial. Many of them are also approved and used in other autoimmune and B cell mediated diseases. So there are other B cell targeted therapies that are being looked at. Burton's tyrosine kinase or BTK inhibitors are an area of interest. Anti-CD19 monoclonal antibodies and anti-B cell activating factor therapies are also being looked at in some clinical trials. Last year there was a BTK trial that failed to meet endpoints in phase 3, but there are a lot of case reports showing that some patients can have significant benefit, and there's some questions about trial design and why it failed. But I think a lot of experts in pemphigus still hold out hope for BTK inhibition as being a potential part of the treatment for pemphigus, at least in some cases. So let's now talk about CAR T cell therapy, or chimeric autoantibody receptor cell therapy. This is CAART therapy, not CAR therapy that we're used to seeing. This is an autoantibody armed T cell. So this, I think, is one of the most exciting and promising anti-B cell treatments under development. If we think about it, the ideal approach to pemphigus therapy would be to completely just delete only desmoglein 3 specific B cells, right? But spare normal B cells so that they can continue to provide immunoglobulin and protect us from bacteria and viruses. And this is the goal of CAR T therapy. Basically, what happens is patient T cells are removed and then genetically engineered to express a chimeric autoantibody receptor on the cell surface. And that is desmoglein 3, an extracellular desmoglein 3 molecule that's linked to an activation and co-stimulatory domain inside the cell. These are then infused back into pemphigus patients where they home in on those desmoglein 3 expressing B cells, link up with them, and induce selective cell death. And these specifically deplete anti-desmoglein 3 B cells. The other interesting thing is that these cells stick around and can turn into memory CAR T cells that can persist long term and give lasting protection against anti-desmoglein B cell recurrence. So you get this kind of immunity against autoimmunity idea, which is really interesting. Right now, there's a phase 1 trial going on with this. It's really expensive at present, and you look at CD19 CAR T cell therapy, which is used in some B cell lymphoproliferative diseases and some autoimmune diseases. It's still prohibitively expensive, but the idea is that if these costs could somehow come down, or the model could be, kind of scaled, this could be really effective and potentially curative treatment for pemphigus. So really interesting from a mechanistic point of view. Here's a schematic of how the process works. Patient blood cells are pheresed, T cells are isolated, they are genetically altered using a viral vector to express this CAR T molecule, which consists of desmoglein 3 linked to an intracellular activator. These then are infused back into the patient and specifically bind to the autoantibodies expressed on autoreactive B cell surfaces and then induce cell death and, stop autoantibody production and lead to clinical improvement, ideally. So far, the therapy discussion is really focused on the B cell axis, but there's also some therapies targeting T cells and T cell derived cytokines that we think are active in pemphigus. So these kind of target a lot of the type 2 inflammatory milieu that we talked about being part of pemphigus, right? So could autoantibodies to things like dupilumab, IL-4, like dupilumab, IL-6 autoantibodies like tocilizumab, teclisumab against IL-25. Could these be helpful in patients with refractory cases? And then also IL-17 inhibition has been looked at too. Remember, we said that there may be Th17 cells at work. There may be increased or overexpression of IL-17 in blister fluid. So perhaps there's an angle there. The other thing is kind of trying to restore or increase peripheral tolerance via the infusion of T regulatory cells. So perhaps if we can clamp down on autoreactive cells by adding more T regulatory cells, that could be a fruitful approach. And then finally, trying to exploit whatever is going on with rituximab, kind of retuning the immune system. We know that some of that may be mediated by the CD40 and CD40 ligand interaction. So the thought is, can we kind of target that specifically by trying to downregulate autoreactive lymphocytes with a monoclonal antibody, the CD40 ligand? And some of this is being looked at in mouse models right now. Then there's targeting the neonatal FC receptor to try and decrease circulating autoantibodies. So the neonatal FC receptor is this molecule that is found inside monocytes and other cells that's really important in regulating IgG homeostasis. Basically, as monocytes kind of penocytose cytoplasm, that cytoplasm has autoantibodies in it, or just regular IgG too. And by binding to the neonatal FC receptor, those antibodies are protected against degradation in lysosomes and cells and are spit back out into circulation. So if you can block the interaction of autoantibody with that FC receptor, the antibody will be degraded and can be removed from circulation pretty quickly by catabolism. And this is actually part of the therapeutic effect of IVIG. It saturates all of those neonatal FC receptors then leads to pathogenic antibody not being able to bind and be protected. And so then it's degraded and those levels drop in serum. And there's been some models of knockout mice that lack the neonatal Fc receptor that seem to be protected against the acantholytic effect of antidisbelium antibodies, presumably because those antibodies are being rapidly degraded by monocytes. There is a molecule that's called efgartigimod that's an antagonist to the the neonatal Fc receptor. And there's been some trials in healthy controls that show that if you give this molecule, you can rapidly reduce peripheral IgG levels pretty quickly without adverse effects. And the thought here is that could this be used in pemphigus as a way to rapidly decrease those autoantibody levels while something like rituximab takes effect? Unfortunately, there was recently a stage 3 trial that failed to meet clinical endpoints in patients with pemphigus. Though I think there's still a lot of hope for these agents, and there are ongoing questions with kind of trial designs with this drug and with others like the BTK inhibitor in pemphigus, because essentially these are being compared to steroid monotherapy. And we know that steroids work quickly to get patients better, and difficult to provide a molecule that does that better, but can we have one that does it more safely? And maybe if we adjust our clinical endpoints, or if we use a different comparator, molecules like this would have better outcomes in clinical trials. Finally, what about localized cutaneous therapy in patients that have maybe one or a few cutaneous lesions or recalcitrant lesions that aren't going away with treatment? It's been theorized that maybe the skin and other protected environments in the body act as these tertiary lymphoid organs and kind of serve as hideouts for B cells that help them evade the B cell depleting effects of rituximab, and maybe could account for relapses too. And there's been case series of intralesional rituximab to recalcitrant lesions, and also people looking at P38 MAP kinase inhibitors topically that have been effective. And could this be a good way to kind of get around some of the systemic toxicity associated with these agents? And I think these could be really useful for patients that do have those recalcitrant lesions, because you will sometimes see patients that get much better, but do have a few holdout spots that can be difficult to fully heal. So let's wrap up with our patient. I think we have reason to be really optimistic about his case. We can start prednisone for rapid disease control with a plan for prompt rituximab treatment to give him the best possible shot and a durable, long-lasting, complete remission off therapy. And there's work being done on curative and non-immunosuppressive treatments like CAR T therapy. However, despite all these kind of steps forward, patients like Mr. Q do continue to suffer. And often there are long delays in treatment, like we described in his case. This leads to enormous social and psychological burden for these patients. And even after diagnosis and treatment, patients can still feel really alone and unseen because it is such a rare disease. And this is where the IPPF can be such an incredible resource for these patients and also for providers too. They provide information about the diseases as well as ways to connect with other pemphigus patients and patient advocates. They are big supporters of providers in their clinical care of patients, and also big supporters of those researching pemphigus and pemphigoid. And Mark will tell us all about this wonderful organization. So with that, thank you so much to everyone. Special thanks to Dr. Richmond and Damsky for the invitation, and to all my patients for all they've taught me and continue to teach me, and to Mark and the IPPF. Thanks so much, everyone.
So I think we're going to do the Q&A at the end. So if Mark would like to share his slides and kind of share his experience with our audience, that would be fantastic.
Yeah, thank you so much. Thanks again for inviting me. Thanks, Zach, for that great presentation, and of course the shout out. So as you know, my name is Mark Yale, and I'm the IPPF Advocacy and Research Coordinator. Happy to be here today and share a little bit about patient experience, but also talk a little bit about the IPPF and what we do. As Zach mentioned, I mean, a lot of times patients feel alone in these diseases. So the IPPF is really there to provide support for patients, families, caregivers, and anyone that needs support during these diseases. So we do a number of different things and Zach alluded to them, to really make sure that we're able to connect patients and really reduce the diagnostic delay for patients. Many patients see anywhere between 5 to 10 physicians for up to maybe even as 10 months before they find a clinician that knows how to treat this disease. And we actually did a study back in 2013 to find, to get that data to find out how long it was taking patients to find a physician. And so we came up with a listing on our website to find a doctor listing that has over 300 clinicians in the US and over 300 globally, that provide patients with a link to find doctors that have experience treating these blistering diseases. So patients can find that information right on our website at www.pemphigus.org. And one of the other things we provide is peer health coaches. So this is a program that we started, again, way back in 2008, and it's trained individuals, peers, people that actually live with the diseases that can provide coaching for patients that have these diseases. And it's a really unique program, but it's probably one of the most beneficial programs that we have, because it really helps patients not only with learning about the basic education of the disease, but also it helps them learn how to manage their disease on a day-to-day basis. So we've got 5 coaches across the U.S. that help provide guidance to patients, and we also handle coach cases globally. So in each year we handle about 1,200 cases of patients that deal with these diseases. The other thing that the IPPF provides is patient support groups. Prior to the pandemic, a lot of these groups were meeting in person. Of course, with the pandemic, everything moved to a virtual Zoom. However, as you can see, we've got quite a few patient support groups around the US. And patients, I think, are now starting to think about meeting again in person. But this gives patients the opportunity to actually meet someone else that has their disease. And many times I'll get on the phone with a patient, and I might be the very first person that they've ever spoken to that actually has this condition. And again, that can be very cathartic and very relieving to patients to understand that they're not just the only one that has this disease. We also provide a lot of educational resources to patients. We have a patient education series, a virtual webinar that we do several times a month that provides basic education. We talk about treatments, management issues, and how to cope and deal with these diseases. And then we have a quarterly magazine that comes out 4 times a year, as well as some other resources like a patient checklist that patients can use when they go to see the doctor. That way they've got kind of the questions to ask their doctor right in front of them. And we know that your time is limited as clinicians. So if patients kind of have an idea what they're going to ask you up front, it can be very helpful to really help them not only understand the disease, but also make them feel somewhat relieved that their questions are being answered. We have a new IPPF guide for those living with pemphigus and pemphigoid. The new guide just came out at the beginning of the year, and again, it's a patient-friendly guide that talks about all of the different aspects of the disease. And now the guide is available not only in English, but it's also available in Spanish and in French. And we're also looking at more languages to roll out in 2024. But you can certainly refer your patients to this guide. It can be found on our website. It can be downloaded on our website. Again, it's a really useful tool for patients and can be a useful tool for you to refer patients to. We have an in-person conference every year. In the past couple of years, it's been virtual, but we're actually going back to in-person. And our patient conference, education conference is scheduled for October this year in Newport Beach, California. Generally, we get about 100 to 150 patients coming together. And, to be honest with you, I think the 2 things that patients want the most is, 1, that connection between themselves and other patients, but 2, also to learn about some of the new therapies that are on the horizon. And a lot of the therapies that Zach talked about, those are things that patients are really looking forward to hearing about. I want to just briefly shift a little bit to our awareness program, and this is the number 2 of our 4 pillars. And we provide a lot of resources for medical professionals. We offer CE courses, as I mentioned, that Find a Doctor map. We also provide patient speakers to come and speak to your patients. We have a number of academic institutions that we visit every year to share patient perspective along with the medical expertise from medical experts. And then again, educational materials for patients as well as comprehensive disease information. One of the things we rolled out 3 years ago is a campaign called Biopsies Save Lives. And you can see here on the right, if you ask your patients, these 4 questions, and if 3 or more, if you can say yes to 3 or more of these questions, then you should probably refer a patient for a biopsy. Zach mentioned these diseases are very difficult to diagnose. And so these 4 questions can really help give you the clues needed to make sure that patients are getting a biopsy and getting diagnosed faster. I'm going to just move on to advocacy real quick. I just wanted to share some information about some advocacy that the IPPF is working on. Right now, we're lobbying with Congress regarding the Providing Realistic Opportunities to Equal and Comparable Treatment Act, or called the Protect Rare Act. So you can certainly go to our website and act now. So please ask your Congress member to take action here. And then next we have another global program that we're working on. This is my friend Noel Modibo. Noel is from Kenya, and Noel has pemphigus vulgaris, and he has started a support group in Kenya. But we're working on trying to create more awareness around all skin diseases across the globe, especially with the World Health Organization. So asking you today to sign on to this open letter. You can use the QR code at the bottom, and that will help us create more awareness with the World Health Organization and world leaders about not only rare skin diseases, but all skin diseases. So we want to make sure that dermatological conditions are a priority. And then just on to some research real quick. I mentioned that map that we have for physicians. If you're interested in joining the map, you can scan the QR code here and join the map, provide us your information, and we can add you to the map, especially if you're treating patients with bullous skin diseases. So please join our map. The more physicians we can get on the map, obviously, the better we can reduce those diagnostic delays that I mentioned. And then we also have a natural history study that was launched back in 2017. So we've been collecting data from patients. Right now, we've got about over 600 patients in this natural history study. And we're collecting data not only on demographics, but also treatments and therapies, quality of life issues, as well as diagnostic delay, as I mentioned. So there's lots of ways for patients to get involved in research and get involved in studies. So please, refer your patients to pemphigus.iamrare.org, and we'd love to have them join the natural history study. We're also working on a survey right now with the University of Emory to recruit specialists in the U.S. Who treat these diseases. It's a quick survey. We're trying to understand particularly how clinicians are treating patients with ocular cicatricial pemphigoid. So there doesn't seem to be any standard of care at the moment. So we really want to try to identify what the standard of care is and really try to make sure that patients that are dealing with ocular disease are able to see the experts as soon as possible. So if you're interested in participating in this research study, please scan the QR code here. And then I've got just a couple of announcements, and then I know we're going to get to questions. First is we've got a meeting of the International Pemphigus and Pemphigoid Foundation in Greece at the end of this year, and it's August 29th through the 31st. Abstract submission is now open, so please, we'd like to get as many abstracts as we can. It's going to be a great 3-day meeting in Greece. We're really going to be focusing on therapeutic interventions, so it would be a great opportunity to meet with your colleagues and really have a robust conversation about the different diseases, and not only autoimmune bullous diseases, but we're also going to have some sessions around other diseases like vitiligo, atopic eczema, psoriasis. So I'll actually have a number of different sessions related to those other skin diseases as well. So please join us in Greece. Registration is now open. And then we have another meeting scheduled, another scientific meeting scheduled in Chandigarh, India this year. And this is going to be more of a regional meeting around autoimmune blistering diseases. And this meeting will be November 9th through the 10th in Chandigarh, India, as I mentioned. And we've got quite a few fantastic speakers lined up. And we're going to be, again, focusing on therapeutic intervention. The other thing that the IPPF does around research is we have a monthly or bi-monthly scientific seminar series. You can scan the code down below here. These events, again, are on either published or unpublished data around autoimmune bullous diseases. And it can be either on basic research or translational research. We've had some really great speakers. That's the first Monday of every month, and it's about an hour long. So recommend that you attend these webinars. They're fantastic information, and it's a great way to collaborate with your colleagues. And our next meeting is going to be May 6th at 11 a.m. Eastern or 1700 Central European time. And we'll be talking about infiltration analysis of eosinophils and basophils and co-expression of CD69, CD63, IL-31, and IgE in patients with bullous and non-bullous pemphigoid. And that'll be presented by Professor Ulrich Rapp. And then our second speaker is Professor Kaisa Tazanen from Finland. And she will be discussing accurate diagnosis of bullous pemphigoid requires multiple healthcare visits. So some great seminars coming up. I encourage you to join. And with that, I'm going to stop sharing my screen, and I guess I'm going to turn it back over to you, and we can do questions.
Awesome. Thank you so much, Mark, for sharing your perspective and all of the upcoming events. And I got to say, your website is phenomenal. It's really nice. It has both, patient-directed and provider-facing resources, and it's really nice to navigate. So thank you. And thanks again, Dr. Schwager, for your, clinical scientific talk. We actually have quite a few questions from our audience. I think I'm going to start with Dr. Ann Rothstein's question. She says, thanks so much. It was an interesting talk. Her question is about the CAR-T approach. It seems that circulating autoantibodies should neutralize the CAR before the T cells can find the B cells. Is there anything done to remove the circulating autoantibodies prior to administering the CAR-T cells?
Yeah, it's really interesting. I had the same kind of thought when you brought up that question. I know that in B-cell lymphoproliferative diseases, when we use these patients are frequently preconditioned with chemotherapy to knock out all of their, native immune cells. Right now, the trial that's going on, it's called the Descartes trial. I do not believe that these patients are preconditioned in any way. Many of them are on immunosuppressive therapies to begin with. So it's possible that in some of them, there are already decreased levels of autoantibodies, though they've been able to demonstrate persistence of the CAR T cells in blood for some time after infusion, despite the presence of the circulating autoantibodies. So that does seem like it would be a concern, but based on the data so far from these trials, without any preconditioning, these patients seem to have persistence of the CAR Ts in their immune system. So I'd be interesting to hear more about someone running that trial like Dr. Worth. I'm sure she would be able to speak on that.
Awesome. Thank you. We have a question from Dr. Yildiz Alte. She says that, well, she's kind of asking about like the chemotherapy, side effect type of thing. And, we use similar dosing, right? So she was wondering if glutamine mouthwash or oral glutamine could be given to protect against oral side effects of PV. And then she has a couple other like related questions, but I thought that was pretty interesting. What do you think about like, support for oral lesions?
Yeah, I mean, I think we're always trying whatever we can for these patients that have bad oral lesions. I find in a lot of cases it's a little bit of trial and error. Obviously, it's difficult to put medications inside the mouth, right? So using a lot of viscous lidocaine, magic mouthwash, steroid solutions as a rinse and spit. Sometimes I'll have patients dissolve a 1 milligram tablet of tacrolimus in water and actually keep that in the fridge and swish and spit with it a few times a day. Intralesional Kenalog can actually work very nicely in the mouth too for recalcitrant lesions. I don't have experience with glutathione, but I have to look into it because I'm always looking for new tricks. What else in there? IVIG, I see they ask about there too. Yeah, I didn't
Yes.
really get into IVIG. I mean, IVIG is something that is very useful in immune blistering diseases and a lot of autoimmune diseases. I kind of hinted at part of the reason we think it might work is by saturating the neonatal FC receptor and increasing autoantibody catabolism, but there's probably many other mechanisms by which it's effective too. Um, we use it, but I think it's controversial what its role is, right? Like it is, I think at this point, it's probably not appropriate for first line monotherapy because of its cost, right? And also because I think it's becoming increasingly clear that with rituximab, there's an element of immune system retuning, right? So there's something going on with these follicular T helper cells that rituximab is exerting an anti-autoreactive effect. And it's not clear that that's seen with IVIG as well. IVIG can be super useful, right? I think for a couple of reasons. Like for one thing, it provides immunoglobulin, right? And we're giving patients with rituximab B-cell depleting therapy. They drop their immune globulin levels. So that can be reassuring to have that on board. Whether or not it provides meaningful clinical benefit in most patients beyond the usual steroids tapered to rituximab is unclear. And does it provide enough benefit to kind of justify the substantial cost? I think that's the question at this point. If cost was no object, I think IVIG is great, right? But I'm not sure that it's that much better than getting some prednisone and rituximab. But it does have its benefits. And we do use it a lot, especially in refractory disease. The point there would be that you got to make sure you don't give the rituximab and the IVIG at the same time, since that's a case where there is concern that the IVIG can kind of mop up the rituximab. So usually we try and separate those infusions by about 2 weeks.
So Zach, is that being used as an adjuvant, IVIG with rituximab?
Yes.
Okay.
Do you know Dr. Razika Med at all?
Yes.
Yeah, he's a big proponent of IVIG, and he has published quite a lot on the benefits of IVIG and pemphigus. I think it's still a bit controversial. I do use it, but it's not in the standard patient. We hope that it's not necessary.
Yeah, as you said, it's probably more for the refractory patients. Probably.
Correct. Yeah. Or if there's a reason that someone is particularly at high risk for infection or can't get rituximab or something else, or is progressing despite rituximab and steroids, and you're worried about their steroid dose, IVIG is a great agent in those cases. It works pretty quickly. The problem is that it doesn't work for very long, right? It works for about a month. So as like a monotherapy or a primary treatment, you're pretty much sentenced to monthly infusions of IVIG indefinitely, right? Which is not an ideal treatment. As for transplants, I think that has been done in the past. But since the advent of rituximab, that's not really thought to be part of the disease treatment.
Can I interject with a quick question related to IVIG? I mean, cost aside, and efficacy aside, I guess, just for the purpose of discussion, is there any evidence that it may mitigate some of the infectious complications of rituximab, or how much, I guess a broader question is how much of a problem are infections with rituximab?
Right. Yeah, I mean, infections are a real problem. I think I didn't have time to really drill down on rituximab, but the biggest side effect of rituximab, right, being a chimeric antibody, there's relatively high risk of infusion reaction. So a lot of patients will get not usually anaphylactic type reactions, but can get IgE-mediated type reactions to rituximab. So there's a whole dosing protocol that involves steroids and antihistamines and things like that. even then, sometimes we need to adjust and change the infusion protocol a little bit. Infection is the main risk beyond that, though. There's about a 1% risk of serious and even fatal infection in these patients. Obviously, it depends a lot on the patient too. I think that the nice thing about pemphigus vulgaris is as compared to something like bullous pemphigoid is, in general, the patient population is younger and healthier. So I feel a little bit better about giving these folks rituximab. I don't give a lot of rituximab for bullous pemphigoid, and that's part of the reason, right? Because I'm afraid for those patients. There's other things we tell patients about. Late onset neutropenia is a risk, as is there's actually a warning against multifocal leukoencephalopathy too, although it's not been described in patients getting this for pemphigus, but in other things too. As for IVIG preventing infection, I don't know how much data there is for that. I think that's pretty theoretical. It makes sense. We use IVIG in other immunodeficiency states, right? So I can buy it, but I don't think that's been looked at. Rituximab versus rituximab and IVIG. I'm not aware of anything. There may be some data out there, but I'm not sure.
Thanks. And we have a follow-up question from Dr. Rajavi. She asks, have you experienced any instances of paradoxical exacerbation of pemphigus following rituximab therapy? And would you share your concerns about those reported cases?
Yeah, I have not seen that phenomenon, but I have heard about it. Kind of reminds me of like how, in psoriasis, TNF alpha inhibitors, you'll sometimes get paradoxical flares. I think the thought is that rituximab, again, is exerting other effects, right, beyond its B-cell depleting effects. So there's something going on there with regulatory T cells and T helper cells that may be sort of disturbing that homeostasis in a way that is producing more autoantibody, at least temporarily. I've not experienced it. I do have concerns about it. And certainly if that was the case, that seems like a good use case for something like IVIG, because I do still think a patient like that could benefit from rituximab, but obviously there'll need to be something on board to kind of get them through that. IVIG can work quickly in that case and could also reduce our reliance on what's typically done, which is just smashing these patients with lots of steroids.
Yeah, and speaking of steroids, we have a question from an attendee about low-dose prednisone for 6 to 8 weeks. How long do the side effect profiles compare, like with a lower dose versus a higher dose for that?
Sure, yeah, or IM dosing versus oral. It's funny, like I just don't do a lot of IM, but I think that's more of a training thing. I don't know, like I've heard of it used. I'm actually interested in using it for some other things, like a couple of patients with very severe and recalcitrant palmoplantar dermatitis. And I've been reading up because nothing's working except prednisone. So I'm like, if he has to be on prednisone, is it better to give low-dose oral or intramuscular Kenalog? There's some older data I think that I was looking into that seems to suggest that IM Kenalog can be safely done. I'm not sure how confident I feel about that over the long term, but it's definitely an option. It may be more convenient for patients. I don't have a lot of direct experience there because I don't really do it. But, there are patients in immune disease clinic, right, that are on chronically low doses of prednisone. You try and get them off completely, but they remain on whatever it is, 1 to 5 milligrams, which is obviously not ideal, but it definitely beats being on 40 mgs a day. So we try our best to get those patients down, but I'm not sure that I would push any of those patients towards intramuscular necessarily.
Zach, do you see any patients with immune checkpoint inhibitor induced pemphigus? Obviously, BP is
So interesting. Yeah, it's so interesting. I was just looking into that as part of this talk. I couldn't find any, because we talk all about, BP, right? But we don't talk a lot about pemphigus, right? And I wonder if part of that is due to this whole, idea around very, very specific autoantibody mediated acantholysis versus BP being more of a, probably I think on a spectrum of just kind of failing self-tolerance that we see in older patients, the development of multiple autoantibodies against different basement membrane zone antibodies, lots of inflammatory cells, which I think is kind of more lends itself to this sort of immune checkpoint kind of phenotype, where I think pemphigus is like a very, very specific loss of tolerance, At least that's my theory. I don't know if that makes sense.
Yeah, no, it makes total sense.
Yeah.
Yeah, it's interesting to think about. I mean, most dermatoses can be seen with immune checkpoint inhibitor therapy.
Right. You don't really
The
see
ones
that.
that aren't as common or interesting. I don't know exactly.
Yeah, exactly. Yeah.
I just, if you guys have another second, I have a quick question for Mark. Do you have a sense of what proportion of patients with pemphigus and pemphigoid are being, advised that your group is out there? Take the US, for example. And then a second question is, are you looking for all patients with a new diagnosis to be connected with you guys, or is it patients that are having trouble coping or, difficult medical management otherwise that you're looking to see? Just curious your comments.
Yeah, great question, Bill. So I would say we probably have maybe 6,000 to 7,000 patients in our database. And that's across the spectrum of the bullous diseases. So pemphigus vulgaris, pemphigus foliaceus, BP, the whole gamut, MMP. So, but that's, as Zach said, there might be maybe 20,000 patients in the US. So it's still a smaller number. And, just I think one of the challenges that we face is, due to the age of most patients, sometimes they don't connect with us on the internet because that's obviously the easiest way to connect with us. So, so that could certainly be a challenge. But, to kind of segue into the second question you had is, we want to be able to support patients,
One
particularly
second.
at the beginning, because that's when patients are the most fragile and need the most help, obviously. So whether it's at the beginning or when they're first diagnosed, to kind of help educate them about the disease and like what to expect. But also for those patients later on that are either have that refractory disease or having flares, having that first flare can be one of the most frightening experiences for a patient, because they may have been in remission or they're able to take therapy and then they're in remission, but now all of a sudden they have this first flare, and all of the psychological impacts of anxiety come rushing back, and they're like, oh, what do I do now about this disease? Is it going to be as bad as it was before? So they ask themselves a lot of these questions, and many times they just have to go back and start some sort of therapeutic intervention. So but I mean, there's a lot of psychological and social impacts and even financial impacts from these diseases that the IBPF can really help with and advise patients with. So whether they're newly diagnosed or have been doing this for a long time, having that sense of community, I think, is really important.
Awesome. Well, I think we're at 1:30, and I think Dr. Schwager has to go to clinic. So I wanted to thank you both very much for sharing both of your perspectives about pemphigus and pemphigoid. It was truly a fantastic Global Derm seminar. So thank you both, and we'll look forward to seeing everybody next time. Thanks.
Great. Thanks so much for the
Thanks so
invite.
much.
Bye.